patho, then there's no way you can really, answer the question. So pathophysiology, you have to be able to define what a fracture is. And then you kind of say, okay, yeah, that, blah, blah, blah. And then you put signs and symptoms with it. How will they present, what are the main concepts that I'm looking at with the person who's immobilized? What are some main concepts that we should kind of like cover with the immobilized patient?
Constipation.
Say it again. Skin integrity. What else?
Constipation.
Possibly constipation from getting so much pain medication. Anxiety.
Muscle weakness.
Someone's saying range of motion back there.
Oh, range. Oh, I'm sorry.
Yeah.
Range.
Oh, I said it like 30 times. I know. Literally.
I didn't hear it. So.
Okay.
No, not you. I'm not talking
All right, so
about
all
No, I
of
said I didn't
those,
hear it.
what about perfusion?
Yeah.
Okay. That restricted, immobilized extremity, right? In traction, in the cast, all of that, right? How do we know if somebody has a cast on and we know they have adequate perfusion? Have a cast on.
Cap refill.
Cap refill. What else?
Pulses.
Say it again. It's on the it's on the foot. Okay, the leg. Okay, dorsalis pedis pulse. Cap refill. The warmth and the color, right? Of the toes and all of that. So we got to do all of that, making sure that perfusion is adequate. So what is a fracture?
Break
The bone. When the resistance of the bone against the stress being exerted yields to the stress force. They can be at any age, right? But are more likely to occur in children and older adults. Because of childhood is a time of rapid bone growth, the pattern of fractures, problems of diagnosis, and the method of treatment differ in children compared with adults. What do you hear most of the time about children after they've had a fracture? Do they have to go to surgery?
No. Usually it'll heal on its own. Depends because they're
Most of the
bendable
time they
still.
do not, right? Because it heals easily, just due to the growth and development. And they may just have to have a cast, right, on for 6 weeks, things like that. Fractured injuries in children are most often the result of traumatic incidents at home, at school, or in a motor vehicle, or with recreational activities. So what are some of the type of fractures? Transverse, oblique, spiral, green stick, spiral. What else?
Complicated. Community.
Community.
Incomplete. Low. Simple.
So maybe just review those. What is a green stick fracture?
Compressed the side bone.
So it occurs when the bone is angulated beyond the limits of bending. The compressed side bends and the tension side fails, causing an incomplete fracture similar to the break observed when a green stick is broken. And everybody know what a complete fracture is? It's probably just pretty much understood there. History, we need to get a history on them to do diagnostic evaluation. Kind of hard to get one on infants and toddlers, right? And even lacking in childhood, in children as well. Because infants and toddlers are unable to communicate. They can't really tell you. Older children may not volunteer information, even under direct questioning. When the injury occurred during questionable activities, whenever possible, it's helpful to obtain information from someone who actually witnessed the injury. In cases of non-accidental trauma, providers may give false information to protect themselves or family members. So they have some of the same symptoms that adults have: swelling, bruising, pain, tenderness, deformity, and diminished function. And they have a big chart, box 48.2, clinical manifestations of a fracture. The generalized swelling, pain, tenderness, deformity, may have the bruising, muscle rigidity, and may have some crepitus, the grating sensation at the fracture site. A nursing alert. Nursing alerts are good to read, and they will inform you of different things. A fracture should be strongly suspected in a small children who refuses to walk or crawl. Fracture. We may do a complete skeletal survey by doing x-rays. What is our goal? We want to regain alignment and length of the bony fragments. We want to regain alignment and length immobilization. We want to restore function to the injured parts. And we definitely want to prevent any further injury and or deformity. It's very important, right? The child be able to walk properly, correctly. So we need to make sure that we take them to the doctor, pediatrician. We probably will send them to the orthopedic, right? Give them orthopedic consult, and the orthopedic doctor will probably care for them regarding that. Do a follow-up with the orthopedic doctor and return back to the pediatrician. So what are the 6 P's that we assess to the extent of the injury? Pain, pallor,
Pulse,
pulselessness,
paralysis,
and
paresthesia.
and pressure. So there's 6 now. Pain, is the pain severe that is not relieved by pain medications or elevation of the limb? Movement that increases the pain. Is there pulselessness, inability to palpate a pulse just to the fracture of the compartment? This is all evaluation of compartment syndrome as well. Is there pallor, pale appearing skin, poor perfusion, capillary refill greater than 3 seconds? Do we have the tingling or burning sensation, which is the paresthesia? What about the inability to move the extremity or digits, paralysis? And is there pressure? Is the involved limb or digits may feel tense and warm? The skin may be tight, shiny. Pressure within the compartment is elevated. And I am going to get to compartment, but I'll just do this nursing alert here. Compartment syndrome is a serious complication that results from compression of nerves, blood vessels, and muscles inside a closed space. This can be very devastating, resulting in tissue death, and thus requires emergency treatment, where they will have a fasciotomy, opening into the fascia. The 6 P's of ischemia from a vascular soft tissue nerve or bone injury should be included in your assessment of any injury. So do you have to just kind of like be aware of the 6 P's? That's very important. Be good in doing your assessment of mobility and things like that. If someone had compartment syndrome and things like that. So may have an epiphyseal injury where the weakest point of the long bones is the cartilage growth plate. And a lot of doctors, that's what they really don't want to see. I had a friend's son playing basketball, I think it's 5 or 6, and almost near, very close to the growth plate. So he did have a cast, didn't have to have surgery, wore the cast for a good while, 6 to maybe 10 weeks. Then after that, they still put him in the sling, wore that for a while, still did repetitive x-rays and things like that. Because if it does, affect the growth plate, then what? That affects the growth of that extremity, right? And so now, he'll have, could have, but, so far, it looks like things are, are well. So that's one thing we definitely don't want to see, because it can affect your future bone growth. What they may have to have, if it did, they're going to have the open reduction and internal fixation to prevent growth disturbances, so they would have to have surgery. So you'll see the open ORIF. They would probably have, and it's just abbreviation for the open reduction and internal fixation. Pins and all at the end. Types of fractures, pretty much identified. I'm not going to review each one of those with the definition. We identified even more clinical manifestations. And so in understanding and studying each one of the topics, your disease processes, disorders, if you know the patho, if you know the clinical manifestations, which are signs and symptoms but the word we use now is clinical manifestations, and treatment, then you're good. It's just no way. And just think of ways you can keep that client safe, prevent further injury, make sure that I'm applying the medication properly, I'm giving the proper medication, I'm doing everything that I can for that client. There's just no way you can answer incorrectly with the test. I'm trying to see what you're on. Anybody looked at the chart in your book about bone healing and remodeling? Trying to see if it's a little bit different. Okay, it's correct. It's still the same. It has not changed from book to book. So is that something that you just really know? Just be aware, And so that's why we say that about children. Bone healing is rapid in growing children because of the thickened periosteum. and the generous blood supply. So when there's a break in the continuity of the bone, the osteoblasts are stimulated to maximal activity. So that's why we say, yeah, children are gonna do fine. They may not need surgery. They're gonna heal, in time. An adult, an adult is totally different. We got adolescent, 8 to 12 weeks, but adults are totally different, right? Much, much longer, may have to have surgery, right? Totally different for us. So diagnostic, do that whole entire skeletal survey. And we're gonna do an entire skeletal survey too on anyone that we suspect abuse. Every time a child is coming in, yeah, we are looking at parents, we are questioning, we are doing good, assessment and all of that. We don't, best parents in the world, that's fine, but yeah, believe it or not, they have ruled out, yeah, that no one has caused harm, caused trauma, things like that. And just depending on some type of fractures, physicians say that they can tell that had to be done by child abuse to the child. Right, the spiral, yeah. So specific, so the skeletal survey, we have to do that. That gives us more information than anyone could ever think, You can tell me that no, you didn't do it, and then sometimes based on how I walk into the room and the parents are just coming with a story. They're coming with telling you immediately before you can ask a question. That kind of like eludes us to think something happened to the child. So we need to correct our PowerPoint because of the change in additions. So you'll see the 5 P's and the 6 with pressure. So just add pressure to that and then you're good.
So with pressure, you're assessing
edema.
Okay.
And so child in the cast, I think I covered that. Read on it. I don't really want to, I don't feel like I just put a whole lot there. Cast care. Can't put ice 15 minutes in the first 24 hours. Sometimes you will see the child immediately after the cast application. We'll have a surgeonette, stockinette on here connected to the IV pump, and we'll have it elevated like that. And so the elevation helps with what? Edema, swelling, and then sometimes you'll see us prop just a couple of pillows underneath the arm and just keep assessing and help with edema as well. So you see sling for support or immobilization. And just you maybe can read over the cast removal, what things that are done, just may want to talk to the child. That's school, not really school age, I don't know. Maybe a little bit of elementary, whatever, probably would understand. We maybe bring a doll in that has a cast, maybe can show them, demonstrate something, I don't know. You don't want to bring in the apparatus that you're going to cut the cast. That probably would frighten the child, right? But you got to just tell them that. Generally, they don't need any pain medication or anything like that. We assess the skin, tell mom that it might be that plaster might still be on, so we might need to clean meticulously and assess for breakdown and things like that. We're going to document if there's breakdown, and then we probably will let the physician come look at it. We're not going to send them home like that and things like that. We said that sometimes the children will complain that it's just so snug and so tight, but they're immobilizing that extremity, and so that's the goal. But we definitely still want to look at, the proper perfusion and the color and the warmth and things like that. And I guess I haven't experienced in a case where a child had to get that cast removed and get another one put on because that one was just really restricting the blood flow. So I think with time and adjusting and wearing it a little bit longer, getting used to it, they do better. All right. I don't say much about leg calf Perthes disease, but you all can tell me what that is and then briefly say something on that. Idiopathic occurs in juvenile ages 2 to 12, but most cases occur as an isolated event in boys between 4 and 8 years of age, with male to female ratio of 4 to 1. The cause of the disease is still unknown, but a temporary disturbance of circulation and vascular supply to the femoral capital epiphysis produces ischemia, avascular necrosis of the femoral head. So that's something we have to do an x-ray on initially. During middle childhood, circulation to the femoral epiphysis is more tenuous than at other ages and can become obstructed by trauma, inflammation, coagulation defects, and a variety of other causes. They do have several different pictures, and it goes through stages 1 through 4 in your book. on the initial avascular stage and how it becomes very, very fragmented, then reossification, and then how it heals there. What may happen, they may reveal only with intermittent appearance of a limp on the affected side or a symptom complex, including hip soreness, maybe very achy, stiffness, which can be constant or intermittent. And the parents may report seeing the child limping, and the limp becomes more pronounced with increased activity. You will see a little bit of that limping too with the osteomyelitis as well, swollen knee area and all of that. So limping, it may be experienced in the hip, along the entire thigh, or the vicinity of the knee joint. Pretty much when they arise in the morning, that's pretty much where they say they have the pain in the limb, more so, and then throughout daily activity. The pain is usually accompanied by joint dysfunction and limited range of motion at the hip. Can't really do much there. Diagnosis is pretty much by radiographic findings, and may even have to do an MRI as well. The initial therapy is rest for activity restrictions, limited weight bearing. The use of NSAIDs helps a whole lot. Steroid, anti-inflammatory medications. Physical therapy to help with range of motion as much as possible, to help restore hip motion and all that. It's just something I wanted to say about. All right, muscular dystrophy. Pretty much the largest muscle disease in childhood, incurable, and most are inherited. Progressive weakness, right. Wasting of the symmetric groups of skeletal muscles. And the most common form we know is the Duchenne muscular dystrophy. Mainly supportive care with the goal being to give optimal functioning. These are part of our treatment plan. Physical therapy, splints and stretching to help prevent contractures. Orthopedic procedures to minimize deformities. As it definitely continues on and gets worse, they need ventilatory support. And then assistance for child, assist the child activities of daily living.
Occupational therapy and PT.
They may have occupational therapy, I said physical therapy, yeah. They have occupational therapists as well, but the weaker muscles are throughout the body. And there's nothing wrong with them having that, continue on until, possibly lead to ventilatory support and things like that. So we do as much as we can, but it's a very aggressive disease. Scoliosis, what do we know about scoliosis?
Deformity of the spine.
Normal curvature of the spine. Maybe seen more in females, more so than males. Pretty much involved in 3 planes: the lateral curvature, the spinal rotation causing rib asymmetry, and in the thoracic spine, awfully causing thoracic hypokyphosis. Most common spinal deformity is classified to the age onset. Congenital occurs in fetal development, could be infantile, occurring at birth up to 3 years of age, and juvenile occurs in children 3 to 10 years of age, and adolescent 10 years of age or older. Scoliosis can be caused by a number of conditions and may occur alone or in association with other diseases. You may see neuromuscular scoliosis. Most of them, they say pretty much we really don't know what is causing it, so they call it idiopathic scoliosis. Most commonly, we see the idiopathic scoliosis identified during the pre-adolescent growth spurt. Parents kind of like bring the child for a follow-up exam, and then they bring a child for follow-up on an abnormal school scoliosis screening. And that's pretty much when we see most of our cases identified by the school nurse. Because of the ill-fitting clothes, such as poorly fitting jeans, school screening is controversial because there are no controlled studies to demonstrate improved outcomes and a report a lot of number of false positive results to lead to referrals. So the American Academy of Orthopedic Surgeons and the American Academy of Pediatrics pretty much says that they publish a joint statement favoring scoliosis screening for pre-adolescents and adolescents in the school provider's offices, or the nurse's clinic. So it can be at any one of those 3 places instead of just really letting just the school nurse pretty much identify most of the cases. Girls should be screened at 10 and 12 years of age, where boys should be screened at 13 and 14 years of age. Early detection is the key. Referral and medical treatment are considered to be significant, but the people performing the screening must be educated in the detection of spinal deformity. So really when the school nurse is identifying it, she's just, identifying that she does possibly see, but she's not diagnosing. And so she's making sure that this child is being seen by his pediatrician. So, we do have the child, we get to do x-rays. We also have the child lean forward, right? And you're looking at the curvature of the spine and identifying all of that. When the child bends forward at the waist of the trunk is parallel with the floor and the arms hang free, asymmetry of the ribs and the flanks may be appreciated, or it may be kind of like enhanced, and that's what you see more so to help identify that. And so the x-ray that they do, they said it's more of a Cobb technique, where it's a standard measure of the angle curvature, and that kind of like gives more information there as well. And the Risser scale also is used to evaluate skeletal maturity on the x-ray as well. So how do we treat it? Orthotic intervention, right? Bracing, surgical spine fusion. Treatment decisions are pretty much based on the magnitude, the location, and the type of curve, the age and the skeletal maturity of the child or the adolescent, and any other underlying or contributing disease processes. And I'm not gonna go over the the treatment operative. You can read on those if you. So being forward, so you can really see that right lateral curvature there, asymmetry of the shoulder and the height, the scapula, the flank shape, or hip height. Bracing, exercise, and surgery. We definitely see a lot of children get it done in the summer. Summertime. In the hospital for a while, a couple weeks or so. It's extensive. They do well.
That way he'll be able to walk when it comes back time for school.
Right. It takes a while, so why not? Not a great time. It's their summer break, but to help them not have to miss, be out of school for that long period of time.
So if a child is diagnosed, they wouldn't want to go ahead and try to fix it before they get older and it gets worse, or would it?
It has to be at a certain degree of bend before they even.
They need to have really growth and development, a little bit of maturity, a little stronger, and all that. And then as she stated, like I said, girls tend to whatever. So by that age, they feel as though that there's really mature development, of the spine. Because things could change, right? It could just automatically just improve on its own, or more so where it does not, require me to do this.
So it can improve on its own.
It's some mental, it's mild. It just depends on the severity and the degree of the scoliosis. I do know some people with mild, you barely can really tell. They just rather, mom didn't want the child to have the surgery, still doing fine, So it just depends on all of that as well. There's always an exception to the rule, right? Time is it? All right. Torticollis, just want to say briefly what it is. Twisted neck in which the head is tipped to one side while the chin is turned to the other. Can be inherited. Maybe took care of one case like that. Develops as a result of damage to the nervous system or muscles or prolonged time in one position. Treatment includes exercise to loosen the muscles, switch the head positions while feeding, carrying, and sleeping. Osteomyelitis. Everybody know about osteomyelitis, right? Affects who mostly? Males. May see in children 10 years of age or younger, boys are more commonly affected than girls. And the median age of diagnosis is 5 to 6 years of age. And that's really when you really do see it a lot.
So when you see it in an adult, it's kind of odd?
Yeah, it's kind of, it's kind of odd, but they still can develop it, But,
okay.
And what we really is, and what the orthopedic surgeon told me, in children, we're really, really running very, very aggressively to take care of this, because why? They're still growing, right? And so this can cause a major problem for them with bone growth and things like that. So, you know, an adult, I'm not saying we're not as aggressive, because we are gonna, you know, probably put PICC line in. They're gonna be on extensive weeks of
Right.
antibiotics too, but just think about the child, you know? Yeah. So Staphylococcus aureus is pretty much the most common causative organisms. Neonates are likely to have osteomyelitis caused by group B streptococcus. So if the neonate, the mother was positive for group B streptococcus, the neonate had it, then they may, and that's probably just may or may not, you know. Pretty much all I'm gonna say there. So we kind of like identify the causative agent. They're coming in for a PICC line, and they can need antibiotics up to 6 months. So sometimes, yes, we are in the hospital 3 to 6 months. Sometimes we will let the client go home and teach mom how to use the pump, and the health nurse will come out and assist her and let her, because that is better for them to be at home. But the non-compliant mother, the physician bases it on what the nurses are saying and what he is seeing. That child remains in the hospital for that period of time. Yeah, because it's very, very important. Do bone scans, do X-rays. You know, 50% are caused by staph. Bone cultures by biopsy or aspirate. Edema, tenderness. Mom said that the child just, you know, they play and stuff, but then they're limping, and that knee is swollen. Mom, she said, don't think much of it, but the child said it's really hurting more. And she may see the increase in swelling even more. And the physicians pretty much know immediately. Seen by the pediatrician. Pediatrician probably sending them directly to the hospital, and he's probably already notifying orthopedics, or on the orders, he'll have an orthopedic consult. This is something that really an orthopedic doctor takes care of. He understands the bone, he understands the bone development much more than a pediatrician. You know, the pediatrician is there, but an orthopedic surgeon is taking care of this, and they're taking care of it very, very aggressively. They're on triple antibiotics, maybe on vancomycin, and have a PICC line, and you're doing what you got to do, and they want those antibiotics given on time, and all of that is very, very important. So they can have edema, tenderness, necrosis, an abscess can develop, temperature chills, rapid pulse. And they definitely, you'll see when they do the CBC, increase in the white blood count. As I said, whenever we have infection in the body, elevated CRP, estimated sedimentation rate, all that will be elevated. And remember that the blood vessels cross the growth plate into the epiphysis when they have this osteo and joint space, which allows infection to spread into the joint. So now, you know, we really are making sure that we take care of this. We're going to do another bone scan after they finish their course of antibiotics and all of that. So organism identification and antibiotic susceptibility testing are essential for effective therapy. Got to do that culture and sensitivity, find out what antibiotic is resistant, what antibiotic is sensitive to it, put them on the proper antibiotics, and start it early, do all that lab work, monitor their CBC, white blood count, monitor their ESR and their C-reactive protein. Pardon me? They will be on any, probably vancomycin and or can be treated with clindamycin. Just depends on which one the doctor. But both of those are very old and very strong antibiotics, and they really, take care of what we needed to take care of. They're on strong dosing of medication for that. We'll assess, for MRSA. So sometimes we put them on vancomycin, we're kind of like covering things well, We're covering everything that we possibly can. We don't want MRSA to develop. And surgery may have to occur. I haven't seen one that I've cared for that had to have surgery, but it could be if that antibiotic therapy is not working. So that might be, a case where, just maybe the child wasn't brought in, maybe they tried to treat it for a while, and it really, really got worse, and really into the bone, to that myelin sheath, and, eating all of that, and so, that's the main thing there. So it definitely says that a PIC line, from your book is the IV of choice. May even put it in a central venous catheter. And that's the reason why, because our PIC lines work better. We don't have time to restart IVs. That's not good. And that child missed a dose. You'd be surprised, even the physician knows how many doses of that medication they should get. You'll even see where most of the time it's numbered. It's numbered as you're giving it. It's numbered.
1 through 10
make
or
sure
whatever.
that child gets. It's just that important, you know, because you don't want anything to ever come back on you that the child was not treated properly, missed the dose. Because even if they miss that dose, we still can change the schedule, and they still should get it, right? Anything else there that I need to say?
I don't think so.
Osteo. So psychosocial could be a problem, right?
Oh, yeah.
Mom, she got to make arrangements. Can she really stay? Sometimes they can't stay off from work. So sometimes, they have to, both parents need to work. Everybody knows how much it is, finances it is to take care of a family. Now you have a sick child in the hospital. So we do understand that as nurses. And so we're there for the child, and we, take care of the child, and we convey their concern to the mother and the father that, just call and inquire and check, but sometimes the child is upset depending on the age and things like that. So we can get them to the playroom or get some toys or get some movies. We do whatever we can to, help. Sometimes the grandparents can be present, sometimes they can't. Sometimes they're not even from here, maybe they're traveling and now this has happened. So just be mindful of that. Just want to say a little bit about osteosarcoma and sarcoma. Pretty much accounts, these are bone tumors. Taking care of maybe one of the sarcoma, female, 15, 16 years old. Yeah, large knot at the knee area. Aggressive chemotherapy. Did well. It was a long period of time, for that. For her to be in the hospital and all that. So we do a CT scan, definitely bone biopsies, because we're definitely trying to rule out cancer, And MRI is definitely good. On our children, sometimes we do the PET scan, kind of like similar to an MRI, and it kind of can identify those who have been diagnosed with cancer and to see if it has metastasized. And so we do a PET scan on our children, and that's just FYI there. And then you have the osteogenic sarcoma. Peak incidence pretty much age 10 to 25, arising for the bone forming mesenchyme. Most primary tumor site is in the metaphysis of the long bones, especially the legs. Greater than 50% occur in the distal femur. Second most common malignant bone tumor in children and adolescents. Is rare in age greater than 30 years of age, but it's the second most common malignant bone tumor there. Not gonna say anything about major treatment, but you do know it's chemotherapy there. Possibly can be. Sometimes we're doing conjunctive therapy in combination, based on the American Academy of Pediatrics for cancers, what their protocol is. Sometimes it needs the client needs the chemotherapy for leukemia, and they need radiation therapy too. Sometimes they just only need chemotherapy, so it's based on that. Sometimes we need chemotherapy, radiation, and surgery. So it just depends on what the protocol comes from that national organization and based for that type of cancer. So, therapeutic management. Let's say that. These medications, pretty much most of them, Cascarito, some of them. Did talk about just saying doxorubicin. And what things that it causes. So before you administer that medication, this chemotherapeutic agent, you have to get a echocardiogram because it causes cardiotoxicity, and the physician just follows the child, closely. GI upset, nausea, vomiting.
Would you give them a medicine ahead of time? If you're going to give them this, would you give them something for the upset stomach before?
That's what I was just going to say. Don't give them an antiemetic. Zofran is the drug of choice that we use most of the time for our children. Antiemetic works very good. A lot of times we're giving it because 9 times out of 10 they are having some problems, nausea, vomiting, whatever, just not feeling well, newly diagnosed with cancer. So we wouldn't give it orally, we would give it intravenously and things like that.
What did you say you have to get? before you do that.
Echocardiogram.
Echocardiogram.
Because it can cause cardiotoxicity, and you will probably have on hand some type of antiemetic, and the one of choice for children is usually Zofran. We rarely get Phenergan.
They're not using Phenergan at all in the
Yeah,
hospital
right, not
much.
even for adults, because we've had some major extravasation and some loss of extremities, hands, arms, and all of that, yeah. But greater than 25 milligrams, they're diluting it, but.
So the medicine that you just said, that's considered under the group of anti-neoplastic.
The doxorubicin, it is an anti-neoplastic medication, or chemotherapy medication.
Okay, I just was making sure, because the syllabus just says anti-neoplastic.
It don't give you, yeah, you're fine.
I'm making sure I'm really.
You don't have to really learn the list or anything like that. We're just trying to introduce this right here. Yeah, this is a little bit up there, so yeah, takes a while.
And we're never even going to give that medicine anyways unless you work in chemo, right?
Right, you have to be chemo certified, so it's a whole nother, which is. Alrighty, those are some of the symptoms that they, and some things that you can do, preventative as much, or to make lesser, less vomiting, less nauseating, stomatitis, maybe hard candies, things like that, oral care, no hard bristle toothbrush, soft, alopecia sometimes. I know some of our teenagers, time they're diagnosed, people might bring wigs in and things like that. Yeah, it's kind of sad, in this situation in dealing with children with cancer. They have diarrhea, things like that. Infection, that's another, with cancer, strict hand washing. Sometimes they are on strict isolation for you to not give them anything. Upper respiratory infections from visitors or anyone, they would rather you not come in the room if you have the runny nose and things like that. And they'd rather another nurse take care of that child. All right, any questions for exam 2? Material, y'all do have
a lot
the
of
review
crap.
at 1 o'clock for those who can. Just study.
Is it in here?
Room 130. At 1 o'clock. Room 130, if you are going, I think they said 1 o'clock, right?
Yes, ma'am.